Ruqayya, should we proceed?
Yes, sir. You're good to go.
Thank you. Hello, good morning, everyone. First of all, I would like to thank everyone for taking their time to join the growth update meeting. Before proceeding to next agenda, I would like to thank everyone and I would like to introduce the panel. We have Dr. Ankita Maheshwari, who will moderate the session. Dr. Ankita has completed MBBS MD Pediatrics and is post-doctoral fellow in pediatric endocrinology. Also completed ESPE Fellowship Pediatric Endocrinology from Southampton, UK, and ISBAD Fellowship in Pediatric Diabetes from Toronto, Canada. She is currently working as Assistant Professor, Sri Aurobindo Institute of Medical Science, Indore, and visiting consultant at Coral Hospital and Research Center, Indore. Now we have Dr. Nikhil Lohia. Dr. Nikhil Lohia is MBBS DNB Pediatrics, FCP Ped Endo, FRCP Ped Endo, and ISPE Fellow Ped Endo from UK. He is consultant pediatric endocrinologist at Silver Lining Pediatric Super Specialty Center for Growth Development and Endocrine Care, Nagpur, and is consultant pediatric endocrinologist at Kings Bay Hospital, Nagpur. And finally, let me introduce Dr. Nikhil Shah. Dr. Nikhil Shah is MBBS DCH Ped as well as DNB Ped and is PDCC Pediatric Endocrinology from Hirabai Kawasi Jahangir Medical Research Institute, Jahangir Hospital, Pune. Dr. Nikhil Shah is currently practicing at pediatric endocrinologist at Smile and Giggles, Chembur, and the Doctors Hub, Ghatkopar, Mumbai since January 2021. And Dr. Nikhil Shah is also associated with many institutes and as an honorary visiting consultant pediatric endocrinology at KJ Sumaiya Hospital, Fortis Hospital, ACE Children Hospital, Dombivli, Bhatia Hospital, Torde, and Cloud Hospital, Malad. And also currently attached as a pediatric endocrine at Neo Plus Critical Care Children Hospital, Borivali. All our eminent speakers come with strong experience in pediatric endocrinology. And with this, I am handing over the dais to Dr. Ankita for further proceeding, so she can take us through overview of short stature in India, followed by Dr. Nikhil Lohia, who will entitle us on case-based approach to short stature. And finally, Dr. Nikhil Shah, who will share his experience through case-based approach in SGA patient. So I'm just moving as well as forwarding the dais to Dr. Ankita. Thank you, Dr. Nikhil Shah, Dr. Nikhil Lohia, and Dr. Ankita.
Thank you, Jiten. Very good morning to one and all. And I extend my warm welcome to all of you for this growth update meeting by Pfizer on this Sunday morning. So for the next 2 hours, we'll be enriching our knowledge on one of the most important, yet I would say most ignored condition in children, that is growth disorders. We know that short stature is quite prevalent in India, but it's prevalent across the globe. Many international studies have actually reported a prevalence of short stature as high as 11 to 13%. Even the developed countries have reported a prevalence of 1 to 3%. Definitely, they have reported more of endocrine causes as the cause of short stature, while in the developing nations, still we are dealing with malnutrition and other chronic disorders. So if we talk about short stature burden in India, we have different studies. So across all parts of the nation, it has been reported that the national prevalence of short stature in India amounts to around 2.8 to 3% in various studies. So if we just calculate that in number, recent 2022 Indian data shows that we have around 444 million children and adolescent population in India. So considering a prevalence of around 3%, if we just calculate the number of children and adolescent having short stature in India, trust me, the number is huge, but the number amounts to around 1 crore and 35 lakhs. Think about it. It's a huge number. Still, would take this number as just tip of iceberg, because what we are lacking in India is a national registry. We still don't register all cases of short stature in India. Many cases are missed, remain undiagnosed, and present to us late. So we don't have a national data, and we can say, so the actual number of short stature children and adolescent, I think, amounts to much more than 1 crore. because most of the cases of short stature report late to a pediatrician or pediatric endocrinologist. But before that, we have talked about the number. But as pediatricians or clinicians, many clinicians do still have a myth that is short stature actually a problem. I mean to say that, do we actually need to consider about short stature, investigate, treat? Why should we do it? I think in pediatrics, we have always read that growth chapter usually comes, growth and development is the key to pediatrics. So always growth chapter comes first in any textbook. So I would say that yes, as pediatric endocrinologist, I would say yes, short stature can be the first clue to any underlying disorder. Not only endocrine disorder, I would say it can be a first clue to any chronic disease, malnutrition, which is still very prevalent in India. And lastly come the endocrine disorders like hypothyroidism and growth hormone deficiency. So it is required that we detect the growth disorders early, which would actually help us as clinician to manage the child effectively. And definitely it would help the patient to lead a normal and healthy life. But more importantly, short stature, short children, I would say, if left untreated or left undiagnosed, would turn up to short adults that we see. Many short adults we still see in our day-to-day practice, which is actually a very big psychological trauma to them and for the whole life. And they just repented that our parents should have taken us to a growth specialist so that 1 or 2 inches would be added to their final height. And when we sit as pediatric endocrinologists in clinical practice, many adolescents do come to us late, and they just beg to us to add 2 or 3 inches to their height. Trust me, we feel really helpless that time that we cannot even give them 1 centimeter. And saying them sorry is actually a big trauma to us also. So the problem is big. The problem is considerable. It should be looked into. But if we look into the causes of short stature in India, so again, we don't have any etiological trends across parts of nation. So etiology is different in different parts of the nation. Like many studies from North have reported, are still reporting celiac disease as very important causes. And Southern studies are reporting pathological as well as normal variant short stature as most common cause. If we talk about 20th century, the studies across India have reported normal variant short stature, that is constitutional growth, delay in growth and puberty, and familial short stature as most common causes. We talk about this 21st century. Over first 10 years, studies have reported pathological causes as most common causes. That might be because of improved nutrition in this century, or most of the data is from hospital-based studies. But again, over the last 10 years, normal variant short stature, familial as well as constitutional delay have again taken over the pathological causes as the most common causes. So in a nutshell, I would say the problem of short stature is still there, still prevalent in India. The prevalence has remained same over last 3 or 4 decades, but etiology changes. So won't go much into details. I think Dr. Nikhil would take as short case-based approach. So won't they go into much details about etiology of short stature? My next question, which Dr. Nikhil and both Dr. Nikhil would be answering, is it treatable? Is short stature treatable? The myth among many clinicians, among many pediatricians still remains the same, that there is no effective treatment for short stature. And many patients do believe, and many pediatricians do believe, that it is treatable with multivitamin supplements or different supplement or protein supplements. But I would differ in this situation, and I would say that we have a very effective treatment for short stature available now. We all know that is growth hormone therapy, and it's in use since last 65 years. Yes, the first growth hormone was used in 1958 for growth hormone deficiency, and since there have been regular additions by FDA to the indications of growth hormone, or I would say to the conditions. So presently in last edition was in 2010. So presently we have 8 FDA approved indications of growth hormone therapy. And different nations or different countries have much more indications than this for growth hormone therapy. And there have been literature, there have been enough evidence to say that growth hormone can be used safely and effectively, and if used at a right time, can actually help the child to get a normal stature and lead a normal life. So I would say, looking at the magnitude of problem in India and an availability of safe, effective treatment, it is the need of the hour to rightly diagnose and timely refer the cases of short stature or any growth disorder to specialist care. I would say pediatric endocrinologists, even pediatricians can treat it well. I won't say that you need to send every case of short stature, but yes, they need to screen it well, diagnose it well, and then only they can intervene. So with today's meeting agenda, that is oath growth, I'd like to emphasize that we as pediatricians and pediatric endocrinologists or any clinician attending this meeting, we need to take this oath not to miss any single case of short stature and how not to miss it. I think the key not to miss it is taking proper anthropometric measurements at every visit. Maybe the child is coming to your OPD for a vaccination, but I would say take height, weight at every visit. Even if you're not, best thing is to plot on a growth chart. But even if you're not plotting it on a growth chart, just maintaining a height on OPD paper helps a lot. But if you have time, you can plot, or you can do it on the app as well. So plotting them on appropriate growth charts, and then only we can intervene them judiciously. So right management can only be done after we have made a right diagnosis. So judicious approach. Now the biggest question is how to judiciously approach a case of short stature. Trust me, as a PG, as a postgraduate, when I was pursuing my post-graduation, I still remember I used to be always perplexed that how to go about a case of short stature. Patient used to come to the OPD, parents used to complain, डॉक्टर साहब बच्चा नहीं बढ़ रहा है, हमें ऐसा लग रहा है कि बच्चा हाइट और इसकी लंबाई या वजन नहीं बढ़ रहा है, and we used to be clueless on how to go about it, just taking a height, taking parents' height, and after that we don't know how to do. Many textbooks have judiciously and very nicely explained it in different chapters on how to approach a case of short stature. But again, as clinicians, we know that every patient is different, and so as our approach. So sometimes those textbook things don't help us practically. So I would like to invite our first speaker, Dr. Nikhil Lohia, to discuss a case-based approach on short stature. Mr. Jitendra has already introduced Nikhil, but I would still take this opportunity to introduce Dr. Nikhil in detail. Dr. Nikhil is a practicing pediatric endocrinologist in Nagpur, and he is attached to Silver Lining Hospital and Kingsway Hospital, and he's running his own OPD very well. He has pursued his post-graduation from Chennai, and then he completed his fellowship from Pune and Elderhay Children's Hospital, Liverpool, UK. He has 31 indexed publications to his credit, and he has presented around 32 presentations at various national and international conferences. His interest for research and academics, I have personally seen it, so it's unmatched. And other than that, he is interested in music. Many a times I see him playing music and playing guitar. So his interest in music is also reflected by his active participation in different music clubs in Nagpur. He has been awarded SP Fellowship in 2019 in Pediatric Endocrinology, and he has won various awards for his presentation in various conferences. So he will make short stature easy for us. So I invite Dr. Nikhil to discuss a case-based approach on short stature. Over to you, Nikhil.
Thank you very much, ma'am. Thank you for that warm introduction. And I'm very delighted to be along with you and another Nikhil. Both of you are very good friend of mine. And it's actually very nice to get along and discuss an area where we all are commonly interested. So without further ado, I would request to share my slides. Okay. So are my slides visible, please? Can anybody confirm? Is it visible in full screen?
Yes, Nikhil, they are visible. You can go ahead.
Thank you very much. So as a general rule, I will disclose that we have been supported by Pfizer for making this activity and delivering this lecture. So let's begin with the concept of short stature. It's a very common thing, as rightly said by Ankita ma'am, like, many times short stature is a symptom. It's a symptom or a sign, whatever you want. If the parent complains, it's a symptom. If they come and you pick up, that is a sign in one line. It's not a diagnosis. Just like fever is a symptom, short stature is a symptom or a sign. You have to make the right diagnosis to come to a conclusion what is the cause of short stature. So before moving to the cases, I would like to have some background about what short stature, what things are, and other things about growth. So it's an integral part of childhood. It's a continuous and an orderly process which happens right from the birth, in fact, intrauterine phase also, and then till the child is adult. And it is very unique in every individual. The usual development is cephalocaudal and growth is actually uniform. Different tissues in the body grows at different rate. We all know the first 3 years brain grows best. Even the physical bones and the length of a child in first 2 years grows the maximum as compared to what it grows in the later part of their life. What are the factors which influences linear growth? Now, if you take the factors, let's divide it into internal and external. Internal factors, what is the genetic makeup of a patient or a child? What is the parent's height? And external means, what is the socioeconomic status, food intake, psychosocial issues, environmental aspects, they definitely matter. So what do I mean by internal genetic makeup and other things? Internal factors also influences your physiology. For example, if someone has got any chronic condition, any disease, for say, let's say celiac disease. So the physiology is disturbed. The body is internally not functioning as it should be optimally. That's why the growth will be affected. External factors, obviously, nutrition is a major component of it. So there is a famous model of infancy, childhood, and puberty, which was given by Professor Karlberg in 1989. In fact, the fetal phase is also there. In that, it is mentioned that infancy phase is a phase which lasts for about 1 to 2 years of age, majorly dependent on nutrition. I repeat, it's majorly, not completely dependent on nutrition. After 1 year, what Professor Karlberg has made a hypothesis or postulated a hypothesis is that after 1 year till the age of puberty starts, it is mainly influenced by growth hormone and thyroxine, which can be seen in the cartoon here. And once puberty kicks in, till the final height is achieved, it's sex hormones, that means testosterone in a male, estradiol in a female, and growth hormone. And there is additional fetal phase also. So if fetal phase is affected, that means the baby has either intrauterine insult or the baby's genetic makeup is such a way that he's born small or she's born small. But let me tell you one thing very clear. There is no thumb rule like this. Yes, majorly if the patient is doing well for first 2 years in infancy, nutrition is major component, growth hormone, thyroxine, and then sex steroids kicks in. What is short stature? A child whose height is below 2 standard deviation for age and gender, it is considered short. Now, how do you make a diagnosis of short stature if the child is not less than 2 standard deviation, or for the matter of fact, what is this 2 standard deviation? So you compare the child's height with population, with the parental expectations, and the child's own previous centiles. So you compare with the population to make sure the child is doing, how the child is as compared to the peers. You compare to the parents whether the child is going along to the genetic expectation or mid-parental expectation. And previous centile, is there any recent or new onset condition because of which the child is going down? So in population, it is if it is less than third centile, it is short. Mid-parent expectation, if the target height range, which we'll discuss in further slide, the child is considered small. If there is a crossover of one major centile, that is considered as deceleration. And another aspect is something called as growth velocity. That means how much the child has grown in a minimum 6 months period. If that is below the 25th centile on the specific charts, it is considered as short. So what could be the cause or the symptom of short stature can be due to what conditions? Short stature, if you make, it could be a normal variant or pathological short stature. When you talk of normal variant, there is a possibility of familial short stature or constitutional delay of growth and puberty. But let me take an opportunity and tell that familial short stature is not always a normal variant. We all know that various genome-wide association studies has given us an idea that there are specific genes because of which the parents are short, and those has been transferred to the kid, and because of that the child is small. So we label them as familial or idiopathic short stature. So it's a gray area, but yes, for the time being, we can consider it as normal variant of short stature. Then pathological short stature is something which is happening inside the womb, and once the baby is born, outside that. So prenatal could be sporadic intrauterine growth retardation, syndromes like Russell-Silver syndrome, Corny-Deligne syndrome, Seckel syndrome, Dubowitz, and Bloom syndrome. When in postnatal, the most common and most important cause of short stature is systemic, which includes chronic malnutrition, renal failure, infections, respiratory and other system disease, which includes bone pathology also, which is commonly missed in our Indian scenario. An endocrine cause of short stature, which forms around 10 to 20% of total etiology of short stature, are hypothyroidism, growth hormone deficiency, Cushing's, pseudo-hypoparathyroidism, and some syndromes which can be overlap of syndrome and endocrine, which includes Turner's, Down, and Prader-Willi. Now, how do you approach a child with short stature? First and foremost thing, if a child is coming to you in your OPD with a complaint of short stature, or you think on your clinical judgment and anthropometric assessment that the child is short, you have to go ahead further. But how to assess whether the child is short or not? Measure the anthropometry. Second, interpret the oxology on your growth chart. Plot them on the age-appropriate growth charts. Take the clinical detail history once you have confirmed the child is short. Do a thorough examination and then subject the child to investigations and further treatment. Now, how do you measure anthropometry? First, you measure length with the help of infantometer, height stadiometer, body proportion, upper and lower segment are important in disproportionate short stature, especially the skeletal dysplasias. Arm span again gives an idea about whether the limbs are short or the trunk is short. Height velocity assessment should be done at least at the minimum of 6 months period. What is the mid-parental height? You measure that. And mid-parental height is assessed with the formula given below. You add mother's height, father's height, and add 13 and divide it by 2 for the boys. And for girls, you add mother and father height, reduce 13 centimeters out of it and divide it by 2. This is how we take length on infantometer, and this is how we take height on stadiometer. Make sure that you have a stadiometer in your OPD. The charts sticking on the wall are as good as of no use. They give you false and erroneous readings. As a pediatrician, I think for us even 0.1 centimeter of height matters. At least to me it does. So even if you take it in a crude way, 0.5 centimeter is also important for us. The paper sticked on the chart gives a very erroneous idea about the height. So avoid them and use standard tools. So let's take an example how to assess the anthropometry of a child. 6-year-old girl, she was brought by the parents that the child is not gaining weight. She's 112 centimeters tall. Weight is 20 kg. Mother and father's height are rightly noted. First, which chart to be used? IAP charts, more than 5 years, and pink color for girls, Blue is for boys. You take the height, weight, and BMI, and we have the height and weight above. The BMI is calculated is 11.5 kg per meter square. You calculated the mid-parental height, which comes around 160.5 centimeters. And remember this, the range of mid-parental height is plus minus 6 centimeters because it is equal to around 1.5 standard deviation at the age of 18 years. Plot them carefully. You can calculate height, age, and weightage and make the interpretation based on population and parental expectations. So this is how the charts are. You can see this is the height of father, mother, and mid-parental height. We have rightly plotted 6 years at this point at 112. The weight is plotted, the BMI is plotted. Based on this, it looks normal, but let's plot the mid-parental height, and on mid-parental height, again, it is normal. So this gives us a fair idea that the child is doing well. So child is normal for the population and parental expectations, and the BMI is also normal. So we have got a new BMI tool inserted in it now. So beyond 8 years, you can use them and we can get a fair idea about weight also in the same page. Remember, as a general rule, if the height is just around 3rd centile, think of constitutional delay, familial cause or idiopathic cause, and SGA. But if the height is very low below the 3rd centile, think of a pathological cause, mainly endocrine, syndromic, skeletal dysplasia, or chronic systemic illness. Clinical history, when did it start, any chronic history illness, whether the short stature is disproportionate, birth, antenatal, family, development history are important. Nutrition is again a very important part of our clinical practice. On examination, you find pallor clubbing for chronic systemic illness, midline defect can be seen for growth hormone deficiency, goiter for hypothyroidism, micropenis and testicular volume, are they descended or not, can give idea about syndromic cause or panhypopituitarism or GHD. Sexual maturity rating is extremely important, very ignored in a pediatric practice. Excess acute fat, hernia, what is the blood pressure, any bony deformities are there or not, what about there are any features of rickets, frontal bossing, depressed nasal bridge, crowded teeth can be an indication of growth hormone deficiency. Coarse skin, delayed denton reflex can be again of hypothyroidism, syndromic stigmata of Turner syndrome are important. Cushing's marker also to need to be looked into. Investigation, make sure you rule out complete, thorough, basic investigation, which includes hemogram, electrolytes, renal function, and rule out renal tubular acidosis if you feel so. Protein also can be assessed. MANTO if you think of chronic fever or recurrent fever, and ESR and CRP for inflammatory conditions. For other bone profile, urine routine, and in a girl child, always do a karyotype. It's mandatory for all girls or any girl who is coming to you with short stature, do a karyotype. Skeletal survey should be done in case of disproportionate short stature, and that's how we can pick up achondroplasia and dyschondroplasia. Thyroxine and TSH should be done in case of suspected hypothyroidism. Bone age is a very, very, very important tool. Make sure we do it. IGF and growth hormone stimulation test probably once you rule out other chronic systemic illness. So let's move to the case-based approach. Let's see our cases. Patient A is a 14-year-old boy who came with a complaint of growth concerns or brought by the parents. Otherwise, the child is fine. Birth, school, developmental history is normal. Father has a history of delayed shaving and his height grew a little late. That's what he said. His height, 14 years, 147 centimeters, weight is 42 kg. Let's plot them on the growth chart. Looks okay, fairly okay, not terribly bad. And then you have plotted it on the mid-parental expectation, but he's on the lower side of mid-parental expectations. So he's considered as short child. Now, once we thoroughly evaluated, we found out that the testicular volume at 14 years is only 4 ml or 6 ml. Just at the start of puberty at 14 years is a little on the later side. Bone age was delayed. It was 12.6 years, but not significantly delayed. It was a delay of about 1.5 years. Hemoglobin was normal, creat was normal, LFT was normal. The child is safely diagnosed as constitutional delay of growth and puberty. These kids usually do well, but if they don't catch up, if they don't get the spurt of puberty, you may need to give them a short course of testosterone. Another patient, this is an interesting patient. He came with the complaint of small genitalia. The grandmother said, "Doctor, the genitalias are small." And the pediatrician actually referred for that purpose, to be honest. And when I probed, I asked, "Do you feel the child is short?" Because I was able to make out clinically. So they said, yes, the child do look that he is short. Otherwise, birth and everything was fine. His height is 99 centimeters at 6 years. Definitely short. Weight is 15. The stretch penile length is 2 centimeters. This is considered as a micropenis. Testicular volume were 1 ml bilaterally. Look at the height plotted on the growth chart. Look at the midparental height. Yes, the midparental height indicates that the child is having familial component also. But again, the question comes here is why the parents are short. So probably some genes have passed on from the parents to the child, and that's why the child is short. Short for the population, but just okay for the parental expectations. But this short stature should not be labeled as familial. Leave them. No, don't do that. Let's evaluate them. Let's see what it comes. So this is how the child was looking. As you can make out that I have purposefully hidden the eyes. The child is having immature facies. He was having midfacial hypoplasia. It's like you can fit it in the matchbox. That's how it looks. Bone age is significantly delayed, 3.7 years. TSH was normal, but FT4 is low. So inappropriately normal TSH or FT4, not okay. Cortisol is 4.5, just at the lower side of normal. So it is considered as low. We did a growth hormone stimulation test on him after starting cortisol and thyroxine. And the basal value was, and the stimulated value was this. So it was a flat response to growth hormone stimulation test. This is how you can look at the MRI. There's no corpus callosum. The pituitary, posterior pituitary is here. The stalk is interrupted. This is the anterior pituitary you can make out. And this child is a multiple pituitary hormone deficiency. Was started on growth hormone therapy and is doing reasonably okay now. Moving to another patient, 15-year-old girl, presented with the complaints of not attaining menarche. The pediatrician said, "That's fine, girl, you little girl, it'll be fine. You will get menarche, don't worry." But the parents were not convinced. So they asked them, "Can we show to someone else?" And then they have referred us. And when we inquired, there is no chronic systemic illness or anosmia or visual defect. Born with a normal birth, no issues. She's 148 centimeters and 35 kgs. There she is. But again, look at the parental expectations. They are belonging to a Punjabi family, which are supposed to be on the taller side. The child is normal for the population, but short for parental expectation. Now again, this is not normal. This is short because she is way below the mid-parental expectations. And as a general rule, we plotted on the BMI tool, which is normal. So we did a uterus, which showed that, look at this ultrasound, look at the uterus, tubular uterus. You can make out with the plus sign, which are located there. Rudimentary, in fact, 4 centimeters, but it is tubular. There is hypoplastic uterus with streaked tissues at the site of ovaries on MRI. So definitely this is looking something beyond. As I discussed earlier, any girl child, short, do a karyotype. This girl was diagnosed to have a 45XO46XY Turner syndrome, as you can make out in the cartoon also. So giving a diagnosis has completely changed everything for this girl. Whole life changed, not just short stature, but she will not have, probably she won't have spontaneous puberty, and the whole scenario is different for this girl now. Another patient, 14-year-old girl, presented with short stature, not attaining menarche or breast development. Now these patients have come associated pubertal delays, obviously there in this girl. So that is another important aspect which we probably can look into and keep in our mind in our routine practice. No history of chronic systemic illness. I think this is what you can make out. She's 140 centimeters. She's 47 kgs. That's where she is. Again, she's short now here clearly. And when we did a bone age, it was delayed. USG pelvis again shows prepubertal uterus, but GnRH stimulation showed a partial response to GnRH stimulation test. The LH-FSH showed a partial response. So we labeled the girl as partial hypogonadotropic hypogonadism, or constitutional delay of growth in puberty is always on the card. Remember, it is always tricky to differentiate such diagnosis, and only on longitudinal follow-up, you will be able to make a diagnosis whether it's CDGP or hypoc. 9-year-old girl again came with a complaint of poor height and weight gain. Birth weight was 2.1 kg. I'm not going to get into detail of this because this patient is an SGA sequelae, which will be discussed by Dr. Nikhil Shah in subsequent slide. The child was treated with GH and did well. So SGA is another aspect which we need to look. Another patient, 7-month-old boy, he had feeding difficulties and growth failure. The birth weight was 2 kg, asymmetric body proportion, prominent ear, clinodectally, and teeth crowding. A few markers that these things are not going on track. Length 57 centimeters at the age of 7 months. Weight is 4.3 kg. Look at the height on the growth chart. The parental expectations are also plotted. It's way below that. Short for population and parental expectations definitely need to walk up. Head circumference, relative macrocephaly is there. And you can make out there is a clinodactyly, and we did a sequencing, Sanger sequencing on this child, and we were able to make a diagnosis of Russell-Silver syndrome based on the mutation. And the child was subsequently treated with growth hormone, and he did fairly well and within mid-parental expectations right now. So syndromic causes like Russell-Silver syndrome are indicated, licensed indication for growth hormone therapy. If not directly under SRS, they can be given under small for gestational age umbrella. 12-year-old girl, another girl, short, and she's slow. She's not very active. The parent says everything was normal. She's 120 centimeters, 25 kgs. And I think the mark is not, so there is the mark. The girl is short for the population and even for the parental expectation. Look at the gap. It's huge. It's way below the centile. This is how she's looking. Mask faces, puffed lips, very immature, dry, coarse skin. Look at her. She is a definite patient with hypothyroidism. I don't need to give any second clue about it. And we did a thyroid function test for her. TSH was very high, and we treated her subsequently, and she's on follow-up with us. So in a nutshell, I would recommend that remember that any child who comes with a complaint of short stature or you find them as short, first plot them on the growth chart. If you missed the patient in early age, the height is lost. What is lost in infancy cannot come back. The lost time or the spent time cannot be brought back. So that's how the lost height cannot be brought back. Girls grow till the age of 17, 18. Boys grow till the age of 19, 20. No, it is not so. Once menarche is there, girls won't grow more than 3 to 4 inches at the max. And if a boy is having bone age of 16.5 years, he won't grow taller. Plot them on the growth chart, make a clear-cut objective inference, and then if required, send to a specialist. Make sure you have a keen or an inclination to make a diagnosis and give treatment. Idiopathic short stature, nothing can be done. No, idiopathic short stature is because of some reason. That's why the parents are short, and they may be helped with growth hormone or other some growth promoting agents. Endocrine disorders are not uncommon. Please keep a keen eye on it and make sure you don't miss any of them. And if you feel so, you can rightly refer them. Thank you very much for your patient listening. And pediatrician friendly charts again are very available, and bone age is a crucial aspect. Timely diagnosis and maybe referral is a key for the benefit of the patient. Thank you very much for your patient listening, everybody.
Thank you, Nikhil. Thank you for making it so easy. So my take home is growth charts, and growth charts, as we have already taught. So I think it's growth monitoring, and growth monitoring. As you rightly told, that longitudinal growth is more important than the cross-sectional growth. So the child may look normal at that time, but the past records would definitely help us. Familial short stature, not always normal variant, but yes, mid-parental height has to be taken in account, because in many cases you beautifully showed that the child was normal for the population, but he or she was short for family. So has to be taken into account. Basics, again, history and clinical examination remain important. As in your case, only the micropenis picked up the DHT. So BMI lookup charts, a new boon for us. We should try to plot the BMI. So busy OPD practice, don't actually go into calculation, just plot on the BMI lookup charts. Karyotype, yes, very important in all short girls, because most of the times even ultrasound do mislead us. They give that ovaries are normal in a 7 or 8 year old girl, but when we do the karyotype, actual situation is different. So karyotype in all short unexplained girls. Bone age, most important tool for us as pediatric endocrinologists. And lastly, timely reference to a specialist. So it's the key, I think, because you rightly said lost growth years are always lost. So timely intervention is the key. So Nikhil, you beautifully explained this ICP model. And in ICP model, you showed that fetal growth is very important. So we come to fetal growth and we come to a very important thing which is called SGA, that is small for gestational age. We all know the definition that if your birth weight or length is less than 10 centile, you call the child as SGA. And yes, the SGA burden is much more. A data in 2010 have showed that around it was 18 million children were low birth weight in India, out of which around 56%, that is 10 million children were born SGA. I think in the last 13 years, the number has increased with many things. We as neonatologists, as pediatricians, everyone sees that SGA is a big burden. And in the first 2 years or first 4 years, as you told, that nutrition is a big factor. So usually they catch up by 4 years. Most 60 to 70% SGAs do catch up by 4 years. If they don't catch up, what to do? So we have our next speaker, Dr. Nikhil Jha, who will talk about short SGA children, or what to do if an SGA child fails to pick up. Again, Nikhil Shah has been introduced, but I'll again introduce him. He has done his MBBS from Karamsad, Gujarat, and then he has completed his DNB Pediatrics from Kachi Komagoti, Chennai. He has completed his fellowship in pediatric endocrinology from HCG MRI under Dr. Vaman Khalilkar sir. And he is currently attached to a list of hospitals. Nikhil, actually, I had to write all the hospitals. It's a big list, actually. So he's attached to Fortis Hospital, ACE Hospital, Bhatia Hospital, Sion Hospital, where he is still very active in academics, AG Samaya Hospital, Cloud9, Neoplus, Royal Hospital, and Nikhil, please pardon me if I have missed one or two. So he has around 20 index publications to his credit, and he's still an active research associate with HCG MRI Pune. So he visits every month to Mumbai and look into the research part. He has presented various papers in national and international conferences, and I think he is into academics since MBBS days. So he has won scholarship in practically all years of his MBBS days. So in all years, he has won scholarship in first year, second year, third year. And he has, I think, got distinction in microbiology and pediatrics. So pediatrics was your interest since UG days. So he has got his fellowship. So an academician, a researcher, still a researcher, and a very good orator, I would say. So he'll discuss case-based approach to short SGA children. So over to you, Nikhil.
Thank you, Ankita ma'am, for the kind introduction. I think I would like to thank Nikhil sir also for laying the groundwork and making it so easy for us to now, take this ahead. So is my screen visible?
Yes, Nikhil, it is visible.
Yes.
You can go ahead.
The overview of today's talk, I'll be covering these points. So first, talking briefly about the prevalence of SGA. We'll be discussing the cases. What is the definition of SGA? Which growth charts we should use? What is catch-up growth? What are the clinical pointers for identification of these children? Evaluation of SGA children. Growth hormone therapy, when to use, puberty in SGA children, and finally, I'll be summarizing my talk. So coming to this slide where we can see the prevalence of SGA babies. So this article, as Madam rightly said, was published in 2013 in Lancet. And you can see the prevalence of SGA in Southeast Asia is around 45%. So 44 to 45% of children born in 2010 were SGA babies, and this number has gone up even further because of the boom of the neonatologists and the NICUs. Out of these 44 to 45% of SGAs, the term SGAs constitute about 41 to 42%, and preterm SGAs constitute about 2 to 3%. So practically, out of every 2 kids, 1 kid born in India is an SGA baby. So the proportion is huge. So I'll straight away dive into the cases, and during the cases, I'll be discussing the academic part. So this is the first case. This child was born of a cesarean section, twin delivery, full term 39 weeks. This is the first twin. Birth weight was 1.9 kilos. So it's a low birth weight child. Second twin was 2.7 kilos. There were no adverse perinatal events. Now the child has come with the chief complaints of not gaining height and weight as compared to the other twin at 4 years of age. So coming to the first part, that is, how do we define SGA children? So before defining SGA children, I think the 3 important prerequisites that we need to know is an accurate knowledge of the gestational age in weeks, accurate measurements of birth weight and length. So a lot of us are taking the birth weight, but hardly any one of us are taking the birth length. So I think taking birth length is very, very important. And we need to compare this against a cutoff, against any reference data from a relevant population. Now there are various definitions used. So do we use the 3rd percentile? Do we use the 5th percentile? Do we use the 10th percentile? So this is where there's a lot of confusion, but the guidelines are very clear. Any newborn child whose weight or birth length is at least 2 standard deviations below the mean for the infant's gestational age, which is equivalent to the 3rd percentile based on the data derived from an appropriate reference population. So any newborn whose birth weight or length is less than -2 SD or less than 3rd percentile is defined as an SGA baby. So now which charts to use, which are the reference data we compare against? So for term babies, we compare against the WHO charts. So you can see these are the IAP modified WHO charts. The left one is the blue chart for the boys and the right one is the pink chart for the girls. So it typically corresponds, in boys, it corresponds to around 2.7 kilos. In girls, it corresponds to around 2.6, 2.7 kilos. So I would say any child who's below the age of 2.7, I think we need to track these babies in terms of growth. Now, what are the growth charts to be used for preterm babies? And that's how when do we come to know whether they are SGA, AGA or LGA? So now the world is shifting from Fenton charts to Intergrowth 21 charts. These are the updated charts which correct for the secular trends. These Intergrowth charts have been made from data from various countries, including from India. The sample population in India was from Nagpur. Using these data, these charts have been prepared. So you can see on the left is the very preterm charts. You can see it starts from 24 weeks, goes up to 33 weeks. And on the right, we have the preterm charts, which goes from 33 weeks to 43 weeks. So these are for girls and these are the percentile charts. So these charts basically should be used for plotting of preterm babies to look whether they are AGA or SGA. So in blue, we can see that these are the appropriate gestational age. So these are the birth weight percentiles and these are the birth length percentiles. So any child who's lying below the -2 standard deviation is an SGA baby. So all the ones in red are SGA. So birth weight or birth length less than -2 standard deviations or less than 3rd percentile is defined as an SGA. So coming back to our case, a 4-year-old boy born as a 4-year-old girl born SGA is come with failure in growth at 4 years of age. So here you can see in the growth chart, height and weight at 2 years and 8 months is below the 3rd percentile. However, at 4 years, the weight has now caught up. Weight which was below the 3rd percentile has now caught up above the 3rd percentile, but the height has still not caught up. Height is still below the 3rd percentile. It is following the same trajectory. Other thing we need to know is, as Dr. Nikhil Lohia explained, that whether this is short for parents. Yes, it is definitely short for parents. As you can see, the mid-parental height is between the 3rd and the 4th line here, and child is way below the last line. So child is definitely short for the parents. And you can see that the height is much more affected than the weight. So coming to a very important concept called as what is catch-up growth. Catch-up growth is defined as a growth rate greater than the median for chronological age and gender. That is, if the growth rate is greater than 0 standard deviations, that is greater than the median for chronological age and gender, reaching a height above -2 SD or 3rd percentile, or target height should also be considered. So this is a little bit complicated. So let's just make it easy. Any SGA child who does not achieve catch-up growth. So what is catch-up growth? Catch-up growth is if you do not reach the third percentile or -2 SD line on the graph, as well as if you compare it with the mid-parental height, if the child is not reaching that, then we call the child as being short. So I'll show you in these charts. On the left, you can see a child at 2 years, 8 months, the weight as well as the length, that is the height, is below the third percentile. But at 4 years, there is a definite catch-up in terms of weight and in terms of length. So this is a catch-up growth chart. And here you can see that the weight has caught up, but the height has not caught up. So this is an SGA child who has failed to catch up. So how long do we wait for catch-up growth? In most SGA babies, catch-up growth is achieved by 2 years of age. So this is a famous paper published in 1995, where they looked at a group of SGA babies. 90% of the full-term SGAs achieved catch-up growth by 2 years, and 80% of the premature SGA babies achieved catch-up growth by 2 years. So most SGA babies will typically achieve catch-up growth by 2 years of age. However, in preterm SGA babies, this might prolong up to 4 years. 10 to 30% of children born SGA do not achieve catch-up growth. The number is higher in India, as published by Khadilkar sir. This number goes as high to 40 to 50%. So 40 to 50% of SGA children do not achieve catch-up growth. They tend to remain short. Now, coming to what are the causes of short stature, this was elaborated by Dr. Nikhil Lohia. So this is the SP classification, that is the European Society classification. And here you will see that under one of the causes of short stature, small for gestational age with failure to catch up growth is a cause of short stature. Yes, this is a cause of short stature, which a lot of us are not aware. So what are the clinical pointers for SGA children? I think the main one which we've already discussed is SGA children who do not achieve catch-up growth by 2 to 4 years of age. They've got some typical faces. In few cases, you will get to see a triangular face, a very broad forehead, and here you can see that there is facial asymmetry. You might get to see a mild clinodactyly of the fifth finger, and there will be limb asymmetry. So again, here you can see this child is having a triangular face, broad forehead, there is limb asymmetry, and the child is also very thin. So coming back to our case, this is a 4-year-old girl who's an SGA born, has failed to catch up at 4 years of age. So this child is definitely short, short for the mid-parental height also. So how do we evaluate any case of short stature? We do a CBC and creatinine, which was normal, a thyroid function test, which was normal. We did a bone age, which was 4 years, which correspond to the chronological age. The IGF-1 was normal. In such cases of short stature, there is no need to do a growth hormone stimulation test as the bone age is not delayed. We started this child on growth hormone therapy. So coming to an evaluation of SGA child who fails to catch up, the first and foremost, it is a clinical diagnosis. We go by history, a proper history at birth, and a good clinical examination. The routine test that we do is CBC, creatinine, thyroid function test, calcium profile. Sometimes we need to do celiac workup. Growth hormone stimulation is not required in all cases of SGA children who fail to catch up. Bone age in SGA children is actually a poor predictor of pubertal timing and height attainment, as it can progress very rapidly. So yearly bone age assessment is not recommended in pre-pubertal children. We just perform it at the diagnosis to see whether it's delayed or not. We perform bone age typically at the age of around 8 years and regularly from the onset of puberty, because it can be advanced in certain conditions like the ACAN mutation. Genetic tests we do very rarely. We do only if there are certain dysmorphic features, major malformations, microcephaly, intellectual disability, signs of skeletal dysplasia. So coming back to our case, this was a 4-year-old girl who was an SGA, failed to catch up. Bone age was corresponding to the chronological age. All the blood investigations were normal. We started this child on growth hormone therapy. You can see we started the child at 4 years at 45 microgram per kg per day, as the child had failed to catch up and the child was short for the MPH. If we had not done anything, child would have fallen below the MPH range. So we started the growth hormone at 4 years of age. We continued the growth hormone for 6 years. As you can see, we've continued the growth hormone till the child is 10 years. The child is now lying within the mid-parental height. A child who was lying below the 3rd percentile is now lying on the 25th percentile. At 10 years, you can see that there is a little bit slowing down happened. So we did an examination, breast development was seen, and there was a slowing of height seen. Bone age was slightly advanced. It was around 11.5 years. So dose of GH was increased to 50 microgram per kg per day, which led to an improvement in the height velocity. The child had menarche at 12 years. The growth hormone was stopped at 13 years. And you can see that the final height of the child is lying within the mid-parental height. An SGA child, if he would have not treated, would have fallen way below the mid-parental height and below the 3rd percentile. But because of giving of growth hormone, the child is now lying within the mid-parental height. So a little bit on the growth hormone treatment in SGA children. What are the criteria? In USA, the cutoff is 2 years. In Europe, it is 4 years. The height HD defined by the USA is less than -2 standard deviations, whereas in Europe, it is -2.5 standard deviations. There is no indication for growth velocity in USA. In Europe, if the growth velocity is less than 0 standard deviations. And again, there is no indication in terms of mid-parental height in USA. In Europe, if the mid-parental height SD is less than the height of the child is less than 1 standard deviation from the mid-parental height, then we can definitely start growth hormone. So typically here we follow the European criteria. Now, is growth hormone contraindicated in any condition? Yes, it is contraindicated in several disorders such as chromosomal breakage syndromes and DNA repair disorders like Bloom syndrome. Hence, it is very important to try to find out the etiology of SGA before starting any growth hormone therapy. The recommended GH starting dose is around 33 to 67 microgram per kg per day. Higher dose is usually used in those most marked with growth retardation or where growth response is unsatisfactory. Now, what is the effects of GH on growth and adult height? So coming to this first graph, you can see these are the various studies. In white are the cases, SGA cases who received GH, and this is the controls who did not receive GH. And this is the mean of all the studies. You can see that the mean height gain was around 1.5 standard deviations in treated SGA children, whereas it was only 0.25 standard deviation in untreated children. So the height gain was definitely more in those who received growth hormone therapy. This is about the mean adult height. So again, the cases are in white and the marked ones are the controls. So those children, and this is the mean of all the studies. So you can see that those children who received growth hormone, the mean adult height was -1.5 standard deviations, whereas those who were untreated, it was -2.4 standard deviations. So they are much more shorter than those who received growth hormone therapy. Now, growth hormone does not only improve the height, there are other benefits also. It improves body composition. It has a favorable effect on the BP profile, improves bone mass, direct as well as an indirect effect. So it increases the muscle mass, which then stimulates the formation of bone mass. There is improved quality of life, decrease in total cholesterol and LDL, and sometimes there might be an improved cognition. Coming to a second case, which is interesting. This is a child born again of a cesarean section, oligohydramnios, full term 38 weeks, birth weight being 1.7 kilos, low birth weight, now comes at 9 years of age for short stature. Mother has also noticed breast development for the last 6 months. So coming to the growth chart, you can see that the height and weight of the child is between the 10th and the 25th percentile. Height is within the mid-parental height target range. On Tanner staging or SMR examination, there is some axillary hair present, some pubic hair present, breast stage 2, and there is no menarche. Height of the child at onset of puberty is around 125 centimeters. So if we just drag this, it looks like the child is going to lie within the mid-parental height range. So how do we approach this child? Do we do anything or leave as it is? So this is where we need to understand slightly about the puberty in SGA children. An SGA child is at a risk of developing premature adrenarche and pubarche. This in turn can lead to rapid progression of puberty. So typically puberty in children will be around 2.5 to 3 years. In SGA children, the puberty might be of a shorter duration, sometimes even as less as 1.5 years. Obesity and metabolic syndrome exacerbate this rapid progression of puberty, which leads to an earlier onset of menarche, leading to final short stature. And because of premature adrenarche and pubarche, they are at a risk of developing PCOS later in life. These are the various studies which have showed that SGA children are at a risk of developing earlier onset of puberty. Here you can see that the difference can be as early as 1 year. The SGA children might get puberty. And here you can see that they have an earlier onset of menarche also. So coming back to our case, we evaluated the child. We did a CBC, which is normal, TFT normal, creatine normal, IGF-1 normal. We did a bone age. The bone age of a 9-year-old child was 10.5 years. So it was advanced by 1.5 years. So if I drag this bone age ahead, you can see that the child is falling below the 3rd percentile as well as falling short for the mid-parental height target range. So as I said, the predicted adult height is falling below the 3rd percentile and the MPH target range. So here comes a question, do we treat this child with growth hormone alone, or do we need to add anything along with the growth hormone, something like a gonadotropin releasing hormone analog? So I think this is very important. Any SGA child who is short at the onset of puberty, so less than 130 centimeters in Indian girls and less than 135 centimeters in Indian boys, or those with an expected short adult height, that is if the final predicted adult height is falling below the 3rd percentile or falling below the mid-parental height target range, I think these children require to be treated with GH plus GnRH, that is a gonadotropin releasing hormone analog. Postponement of puberty with a gonadotropin releasing hormone analog for 2 years in addition to GH in these children results in an average improvement in adult height of roughly around 6 to 7 centimeters above the height achieved only with GH. Again, we need to understand not all cases require GnRH, only those children who are short at the onset of puberty, that is below 130 centimeters in girls and less than 135 centimeters in boys, GnRH can be offered along with GH. So coming back to our case, at 9 years of age, because the bone age was very advanced, which is 10.5 years, the child's predicted adult height was falling below the 3rd percentile, as well as below the mid-parental height target range. We started the child on GH plus GnRH. Following the initiation of GnRH, you can see that the bone age progression has slowed down. We stopped GnRH after 2 years, that is at 11 years, we stopped the GnRH. The child achieved menarche of 1 year stopping of GnRH. GH was continued for 1 year post menarche, so we continued GH till 13. As a result, the child has now reached within the target adult height. A child who was going to fall below the 3rd percentile and below the mid-parental target height, by giving GH plus GnRH analog, we've achieved them to reach their genetic potential. I think in a topic of growth, we should not forget that all of these children are metabolically programmed to have some long-term metabolic complications. These children are at a high risk of developing obesity, insulin resistance, metabolic syndrome, PCOS, dyslipidemia, and type 2 diabetes. So we need to screen these children and treat if required. So what are the take-home messages that we've seen today? Use of WHO charts for term infants and Intergrowth 21 charts for preterm infants for plotting of birth weight and length according to the gestational age. 10 to 30% of SGA children do not undergo catch-up growth by 4 years of age. So this is the first critical period which needs to be examined by the pediatrician. Growth hormone therapy is a licensed indication for SGA who fail to catch up by 4 years of age. It is completely been licensed by the US FDA as well as the European agency. Rapid progression of puberty and earlier onset of menarche leads to final short height. So any girl around the age of 6 to 7 years and boys around the age of 8 to 9 years need to be again examined for the SMR staging. So I would say that this is the second critical period which needs to be kept in mind. Any SGA child who's short at the onset of puberty, treat with GH plus GnRH, and never to forget to screen for obesity, metabolic syndrome, insulin resistance, PCOS, and dyslipidemia. Final slide, I think, which has been very well enumerated by Ankita madam also in a first talk, is birth weight and length measurement is very important. So early identification, regular monitoring of birth weight and length is critical. So early monitoring, early and timely referral to growth specialists. So that is early referral, and appropriate initiation of GH at 4 years leads to better outcomes. So early treatment. So early identification, early monitoring, early referral leading to early treatment and better outcomes. Thank you.
Thank you, Dr. Nikhil, for taking it up so smoothly, making it so easy, and finishing it on time. So again, take home SGA burden. Actually, I agree, it is huge, and as you told, out of 2 kids, 1 is SGA. That's I think it's really worrisome. So birth length is important. You told we should use intergrowth charts. It's time now we should move from Fenton's to intergrowth because India was a part of the data. Bone age, that's a very important point you told. In SGI, it doesn't need to be monitored regularly. So we need to do it at initial assessment and then definitely after 8 years, because we have to look into the puberty of these children as well. Even IAP recommends that we have to do SMR of all children from 6 years. So yes, SGA, you have to do SMR for all children from 6 years onwards. Growth hormone treatment, safe, effective. And we do follow the European consensus. So yes, your point was really valid that we should wait at least for 4 years before jumping onto growth hormone therapy. But most important is know the etiology. So I think as a clinician, we should never forget, do no harm to the patient. We might not do benefit to all the patient, but do no harm. And metabolic complications. So screening and follow-up. I think that's more important. Even if you have, even if you have stopped growth hormone therapy, the child has achieved a normal stature, but still you need to follow them up. You need to properly transit them to either adult endocrine care or not care because they are at risk for PCOS and other metabolic complications like type 2 diabetes. So they need to be followed up, I think, for their life. And the best thing is IMRT, Identification Management Referral Treatment. So we should remember it as IMRT. So should we take up questions? Dr. Nikhil, can you unmute yourself? So we will take questions simultaneously for both of you.
Yeah, sure.
So my first question is for Dr. Nikhil Lohia, as both of you are Nikhil. So Dr. Nikhil Lohia, you talked about GHD. So how prevalent is or how common is growth hormone deficiency in India? And do Indian GHDs or do Indian growth hormone deficient children have a different phenotype as described in the standard texts, or are they same?
Yeah, so the prevalence of growth hormone in India has not been very well documented, to be honest, but what the textbook says is somewhere in 1 to 3 to 5,000. But I must admit that it is much more than what it is. I feel in the clinical practice that they are more common. Maybe we are working in a referral center, that's why, but I personally feel that it has to be somewhere as a guess. Let me not guess it because it might be very inappropriate, but it is much commoner than what it is quoted in the textbook. And about the phenotype, yes, what type of growth hormone deficiency you have, it depends on what genetic mutation and what type of mutation you have, whether it's the growth hormone gene or growth hormone receptor, or GHRH, growth hormone is secreting hormone receptor. All those things, they are responsible for it. In one of the paper which is published in, I think, 2014 by Khadilkar sir, it is very clear that Indian growth hormone deficiencies have different mutation as compared to what are the Western counterpart. And clinically, obviously, we don't get a very classical picture of what chubby baby of growth hormone deficiency. But yes, if it is prolonged growth hormone deficiency, we do get it. But not necessarily always you get it that way.
So truly said Nikhil that we don't or cannot always rely on the phenotype. So I think it's the anthropometry we should rely on.
Always.
And I think still we need to have a national registry in India so that we actually get to know the right number of GHDs. You are right in saying that we might be underestimating growth hormone deficiency.
We are doing that.
So Dr. Nikhil Shah, I have a question for you. We talked about the definition of SGA children. You told that it is less than third centile or -2 standard deviation. But many neonatologists or even in neonatology textbooks, they say that we should take 10th percentile as cutoff. I mean, it doesn't make much difference. But what do we follow as endocrinologists?
As endocrinologists, we follow the third percentile because the recent consensus statement also has clearly stated it's less than the third percentile. But I think we could make it easy for a neonatologist or for a clinician is anything less than 10 centile, keep monitoring. And if there is no catch-up growth at 4 years, then we can intervene. So not too much of a difference between third percentile, 10 percentile. It's like nitpicking. So any child less than 10 percentile, I think needs proper monitoring. But the consensus statement is very clear, which was released last year, is less than third percentile or less than -2 standard deviations.
So I think it's 10th percentile monitoring, IRIS, and 10th, third, less than third definitely needs to be
Definitely.
referred. And what is the ideal time for a pediatrician to refer an SGA child?
I think more than referral, I think they themselves need to monitor, I would say. Please monitor the weight as well as the height, track on the growth chart. By 4 years of age, if the child's height is less than the third percentile, or the child is not reaching the mid-parental height target range, then I think they need to refer or evaluate as to why the child is not reaching the genetic potential, because all the SGA babies should catch up by 4 years of age, not after that. So if by 4 years, if a child has not caught up, this child definitely requires an evaluation as to why the child is being short.
So I think 4 years is the key. Not picking up, you should not wait till 9 or 10 years or
No, no.
pubertal onset. So it's 4 years. Nikhil Loya, Dr. Nikhil Loya, we talked about normal variants of short stature, and still many studies show that constitutional delay in growth and puberty still remains the most common cause, especially in boys. So again, the question remains the same. What is the best or the ideal time for a pediatrician to refer CDGP? And I mean, I would rephrase my question. Till what time a pediatrician can conveniently wait before referring a CDGP to a pediatric endocrinologist?
So constitutional delay of growth and puberty is a diagnosis of exclusion, number one. So the moment you find the child is short, and if you are capable of doing a bone age appropriately, you do it. If it is delayed, you see that the child is having delayed puberty, you can safely wait till the age of 14 years if the compromise in height is not much. Let me repeat, you can wait till the age of 14 years in boys till the compromise of height is not much, as long as the child's growth velocity is okay, as long as the child is following a centile or growing along the lower centile. But the moment you see a deceleration, the moment you see that this is something beyond, the moment you see that parental anxiety is more, the moment the child is aged 14 years, I would suggest that you refer the patient, because constitutional delay of growth and puberty is a diagnosis of exclusion. You may not always come to a diagnosis of that. Number two, many times this patient needs a short course of testosterone. Well, some papers have also said using growth hormone can help, but I doubt that, to be honest. And number three, growth promoting agents can be used in these kids, which can help in gaining about 1 to 2 inches of height in the final height. So we can do much more better, or rather I should say we can do much more justice to these patients by doing some giving growth promoting therapy and giving a short course of testosterone if the child is constitutional delay of growth and puberty. Situations are the child can be a partial hypogonadism also. So then that is a nightmare. Nobody can comment on that, and pubertal induction might be required, and you may stop the treatment by 16, 18 years, and then the child will have spontaneous. So my suggestion will be, as long as growth is concerned, wait till the age of 14 years if the child is growing well. 14 years refer. Before that, if you find the deceleration is there or the things are not okay, parental anxiety is there, refer.
I think monitoring growth and 14 years.
Yeah.
So, Dr. Nikhil Shah, you already mentioned about that growth hormone stimulation may not be required in all SGA children. So, again, is it required in all SGA children, or do we screen them with certain things before
I think
or not?
bone age is the most, I think as Nikhil Shah very well shown in his graph, that the anthropometry will tell us, where the baby is lying. A child just below the third percentile, it is more in terms of either a CDGP, familial short stature, or SGA. If it's way below the third percentile, then you're looking at pathological. So SGA children usually, unless if it is not syndromic, will typically be just below the third percentile, slightly below, but not very below. So that is the first clinical clue on examination. Second thing, bone age. Bone age, if it is not delayed, then definitely it's not an endocrine condition. A bone age which is very delayed, then you should start thinking in terms of endocrine condition. And if the bone age is delayed, then we can do tests like screening IGF-1. If the IGF-1 is low, then we can plan a GH stimulation test. In a resource limited setting, if a short child is there with a very delayed bone age, then directly do a GH stimulation test.
So I think anthropometry, bone age, and if required, IGF-1. And suppose we do a joint stimulation test in such kids, in SGA kids, does the dose of growth hormone differs in a growth hormone deficient versus a growth hormone sufficient SGA child?
So this is for treatment, I guess, ma'am, you're asking. Yes. So
Yes,
growth
treatment,
hormone
dose of growth hormone.
growth hormone deficiency, you require a much lesser dose. You can get away with 20 to 30 microgram per kg because these are deficient children. In SGA children, because there is some amount of resistance there, you require slightly higher doses. Doses can range anywhere from 33 to 67. We routinely in practice give around 40 to 45 microgram per kg per day, and children typically do well. So yes, SGA children require higher doses of growth hormone as compared to growth hormone deficiency child.
If an SGA child is growth hormone deficient, what will you do?
Then I
Will
would
start with the lower dose or
then I
higher
will start
dose?
at the lower dose. Start at the lower dose.
Lower dose, and I suppose we see the response and then we
Yes,
go
yes.
ahead.
Start at the lower dose.
Okay, point well taken. Let's start with the lower dose. Nikhil Loya, can you just shed some light on growth hormone therapy in Turner syndrome? You told that karyotype is a must. We pick up Turner syndrome. I mean, what is the ideal time? What is the dose? And how to monitor a Turner girl when she's on growth hormone therapy?
Yeah, so first of all, Turner needs a multifaceted approach. I mean, yes, growth is one aspect which we look into, but you obviously have to look into other areas. As a pediatrician, I think people need to make sure that they are not dealing with celiac and other diabetes, or 2D echo should be normal. And for the matter of fact, hearing assessment also should be done. As far as growth hormone therapy is concerned, the dose of growth hormone is higher for Turner syndrome. In fact, almost, not twice, but almost twice of what we give in growth hormone therapy, growth hormone deficiency. Another aspect is the mosaic variant of Turner do slightly better as compared to the classic Turner of 45XO. And it has to be given for a longer period of time, and subsequent monitoring is very essential in them. Anything which I'm missing? I'm sure. Can you repeat what areas you asked into? Because
I just asked about ideal time. You took it up.
Yeah, right time. So Professor Keighley actually started a paper on toddler treatment in Turners. Initially, at the age of 5 years or 7 years, when they did the analysis, it showed a little better response. But the final height paper is out, and it was published last year in Hormone Research in Pediatrics. It has showed it doesn't make a significant difference. So my suggestion as an endocrinologist will be, practically speaking, refer as soon as you've diagnosed Turner. Don't wait. There are multiple reasons to it. The parents take time to absorb. There are a lot of other aspects. Bones need to be taken into account. If there is something like, they are coming late, pubertal induction also has to be thought for. So don't wait for Turners. Ideal age, I think somewhere around pre-pubertal 4 to 10, anything between 4 to 8 years, if you start, it should give a fair good response. That's a personal take, but as long as you treat, it should be fine, I think.
I think it's the earlier the better. And you rightly pointed out that parents take time to accept. So you need to have a lead time of at least 6 months to 9 years. 6 months to 9 months for the patient to absorb and accept that the child needs growth hormone. And yes, monitoring in Turner girl on growth hormone is slightly bit different from what we do in other cases like growth hormone deficiency. So, Dr. Nikhil Shah, my next question is for you. Do we actually need to evaluate all SGA children who have developed axillary and pubic hair before the age of 8 years? As you told that puberty can come early and premature adrenarche is also common. So do we need to evaluate all children?
Yes, at least we need to do a bone age. We need to see if the bone age is advanced, then we need to look at if puberty is set in. If it's just a premature adrenarche, if the bone age is not very advanced, then we can just wait and watch. But if the child has definitely developed features of precocity that is before the age of 8 years, then I think we need to evaluate. So bone age would be a must. And you will have to treat, because if it is precocious puberty, because the final height will drop down. And in SGA, bone age is not very reliable. So there is going to be a rapid progression of puberty. So what might seem is going to be the final height today might not be the same thing after 6 months. So I think I would keep a little bit low threshold that treating. And again, the guidelines are very clear that any child shot at the onset of puberty, along with GH, GnRH does add some benefit. So yes, at least they need to be evaluated and they mostly will require treatment.
I think GnRH analog use, judicious use of GnRH analogs in SGA is a must. So, Dr. Nikhil Loya, my next question is for you. You told about idiopathic short stature. So, I would say it's still an umbrella term. If we are not able to find out any cause of growth hormone, any cause of short stature, it label it as idiopathic short stature. But FDA have given clear approval to growth hormone therapy in ISS patients in 2010. So can you share your experience of growth hormone treatment in idiopathic short stature patients?
Yeah, so it does work. See, about 70% of patients, even literature says it does work, but you have to treat it for 6 months, see whether the height is growing well, there is a crossover of centile or improvement in the Z score, and then you continue subsequently. But the catch is it won't work for everybody, just like liraglutide, which is available, it won't work for everybody. I think this also doesn't work for everybody, but it works for 70%. Rather than looking at those 30% who doesn't, this 70% should be looked into. Don't dismiss the patient. My only objection is don't dismiss the patient. Kuch nahi ho sakta. Don't do that. Don't do that, because then they come after the age of 16, come to us and we are helpless to do anything. So before that, things can be done. And yes, 70% of them, they do response, and the response, we don't treat them rampantly. We obviously monitor them that whether it's going appropriately or not. If it's going, we continue. Otherwise, we clearly say, I think it's not possible. So probably we can go for other growth promoting agents rather than growth hormone.
So yes, it should be tried in idiopathic short stature, as FDA says as well. So I think we are done for the day. Any more comments from Dr. Nikhil Shah and Dr. Nikhil Loya?
I think I'm done. Do you have anything? Do you have anything, ma'am, in your mind?
That's it.
I think the most important take home is growth charts, and growth charts.
That's always there. That's always there.
Everything comes last, but I think first comes the growth charts, and appropriate growth charts. So,
Any other questions, Jiten, Manishi, in the chat box?
I'll just check it. I don't think
Okay.
there are any more questions. So we can just wrap up. Mr. Jiten, can we just wrap up?
Yeah. So there are no further questions in the chat box, and this is a wonderful session. And at the fag end of this Oath for Growth update meeting, first of all, I would like to thank our panelists for sharing their valuable insights and experience with us today. And we have covered a lot of the ground, and I hope you all will find this discussion to be very informative as well as thought-provoking. As we wrap up, personally, I found it fascinating to hear from our panelists on SGA, growth deficiency, short stature, and so a lot more, and definitely growth charts. And I would want to thank panelists once again for their time and contribution. And if you want to learn more about their work, you can get in touch with them. Finally, I would like to leave you with call to action. And thank you once again for joining us today. And I look forward to continuing this important conversation in future on Growth Update meeting. So thank you, Dr. Ankita, Dr. Nikhil, Dr. Nikhil Shah, and Dr. Nikhil Loya. Thanks a lot, sir. And thank you, Manish, for coordinating the meeting.
Thank you,
Thank you very
Pfizer
much.
team.
Thank you very
Thank
much.
you. Thank you.
Thank you,
Thank you,
Dr.
ma'am.
Nikhil. Thank you, Dr. Nikhil,
Thank you,
Dr. Nikhil Loya, Nikhil
Thank you,
Shah.
Ankita, ma'am.
Thank you, ma'am.
Nikhil.
Thank you, Nikhil.
Thank you, sir. Thank you for a wonderful session. Thank you, sir.
Thank you.
Bye. Bye.
Bye.
So with your permission, can we close the meeting?
Yes, please.
Thank you, sir.
Yes, thank you.